Okay, this is the second time around recording this section of the PowerPoints. I completed the entire recording and something got stuck at the end and I lost it all. So I'm not very happy right at the moment, but I won't let that interfere with my presentation. Colorectal cancer is the most common form of cancer, and it is in fact the second leading cause of all cancer-related deaths in the United States. It has an insidious onset, and symptoms don't appear until the disease is pretty well advanced. So as registered nurses and healthcare professionals, we want to promote early detection through screening, and we'll talk a little bit more about that as we go through these slides. The majority of the colorectal cancers arise from adenomatous polyps, which are neoplastic polyps. We talked about polyps in class today, and we know that all polyps are considered abnormal and should be removed. This screen simply shows the incidence of the colorectal cancers in terms of location, broken down by male and female. Mortality rates are higher among African American men and women than they are among Caucasians. We know that colorectal cancer is more common in men, and there are certain risk factors that we can educate our patients about so that they're aware that they may fall in one of those categories and have a higher risk for developing a colorectal cancer in their lifetime. Those risk factors include familial history of colorectal cancer, increased age. About 90% of the new colorectal cancers that are detected in people are in individuals older than the age of 50, which we know, of course, is the new middle age. And about a third of those that are detected occur in patients with a family history of colorectal cancer. So familial tendency and increased age. Colorectal polyps, if they've got polyps, they are certainly at a greater risk for developing colorectal cancer. And the presence of an inflammatory bowel disease also puts them at risk. Again, with Crohn's disease, a higher risk of developing cancer of the small intestine, and ulcerative colitis patients have a higher risk of developing colorectal cancer. Additional risk factors include obesity, smoking, excessive alcohol use, and a large ingestion of red meats. We know that physical exercise and a diet that is abundant in fruits and vegetables and grains may actually decrease the risk of developing colorectal cancer. So, of course, we want to promote this information or share this information with our patients. Adenocarcinoma is the most common type of colorectal cancer, and it arises from adenomatous, I have a hard time with that word, adenomatous polyps. So again, get those polyps removed. What happens is that the tumor spreads through the wall of the colon into the musculature, and then it invades the lymph system and the vascular system in the form of metastasis. Here's a diagram from the text showing you the side A is the carcinoma of the cecum, and side B is a carcinoma of the descending colon. If you notice the arrows in this image on the right, they identify those polyps that we're talking about, and those polyps are neoplastic and promote cancer. Okay, the most common sites of metastasis are the lymph nodes in the region of the colon, that part of the colon that's affected, the liver, the lungs, the bones, and the brain. And we also know that the cancer can spread directly into adjacent structures. So when surgery is going on, the surgeons are very carefully examining all surrounding areas to make sure that any of the cancer that has spread to surrounding tissue or structures is removed as well. clinical manifestations of colorectal cancers, typically very nonspecific, and many of the same symptoms occur in patients with Crohn's or irritable bowel syndrome or ulcerative colitis. So it can make diagnosis difficult unless we go through some specific procedures. What's also very interesting is that the symptoms don't appear until the disease itself is pretty well advanced, and that the symptoms themselves vary based on the location of the cancer. Cancer on the right side of the colon gives rise to clinical manifestations that are different from those on the left side of the colon. I kind of find that pretty interesting. So symptoms of left-sided colorectal lesions include rectal bleeding. Change slide there for you. Alternating constipation and diarrhea, a change in the consistency of the stool itself, and individuals typically have a sensation of incomplete evacuation when they defecate. And then symptoms of right-sided lesions for colorectal cancer are the individuals are more typically asymptomatic. They may have vague abdominal cramping or colicky abdominal pain. So difference between right and left-sided manifestations of colorectal cancer. All right, let's skip that slide. Diagnostic studies include an in-depth analysis of family history, a good physical examination. A digital rectal exam can detect lower lesions in the colon or rectal area, and of course a colonoscopy. And beginning at age 50, both men and women are at an average risk for developing colorectal cancer, and both males and females should undergo screening tests. Now, the colonoscopy is great because it can detect polyps and cancers as well. So a colonoscopy is a great diagnostic tool to screen for the presence of polyps and to also screen for the presence of cancerous lesions in the colorectal area. It's considered the gold standard. The entire colon is able to be examined. Biopsies can be obtained, and any polyps that are identified through the screening can be immediately removed and sent to the laboratory for examination. Colonoscopies are recommended every 10 years or more frequently if there are positive findings or if you have a familial history or you're at high risk for colorectal cancer. But an average of every 10 years, beginning at the age of 50, for colorectal screening with colonoscopies. The tissue biopsies will actually confirm the diagnosis, although experienced surgeons are going to be able to tell by visualization of the lesions. Additional lab studies are also done and to diagnose colorectal cancer, and that would include CPCs, coagulation studies, and liver function tests. CAT scans and MRIs are also helpful in detecting metastasis to other organs, and also helpful in detecting the depth or the penetration of the tumor into the bowel wall. The prognosis and the treatment are both correlate with the pathological staging of the disease. We seem to have a staging system in place for most diseases, and the TNM system assesses the tumor, assesses the lymphatic nodes, and the degree of metastasis. And depending upon those findings in all three of those categories, the cancer will be staged. The survival rate for individuals who have localized cancerous lesions only is much higher than individuals who have lymph node involvement, and that is much higher still compared to individuals who have distant metastasis involvement. So, in general, the prognosis worsens with the greater size of the tumor and the depth of the tumor as well. Surgery is the only cure for colorectal surgery. During colonoscopy, those polyps are going to be removed. If the cancer is localized, it can be actually cut out or resected and removed. And sometimes the healthy ends of the bowel can be reanastomosed during that surgical procedure, and then the individual would come out of surgery with with a reanastomosed bowel internally. Sometimes it's not the timing isn't right for the bowels to be reanastomosed, and that individual may come out of the surgery with a colostomy that may be considered temporary. Maybe allow the bowel inflammation to subside, and later on go back in and have a surgical reanastomosis or resection of the part of the bowel that was the ostomy, resected to the healthy part of the bowel that's in the gut, and that individual can then go through life hopefully without an ostomy. Okay, during that surgical procedure, the removal of any lymph nodes that are involved, that's going to be really important to make sure that they're not missed. And very often, post-operatively, the patient will have adjunctive therapy with chemotherapy and/or radiation therapy, especially if the cancer had spread to the lymph nodes or into nearby tissue, or if there's any question that it had spread into any of those areas. So again, the surgical goals: completely remove the tumor, thoroughly explore the abdominal cavity, make sure that all of the lymph nodes that drain into the area have been removed, because they may have been involved in the metastasis. They want to restore the bowel continuity, if at all possible, and the prevention of any surgical complications. If the bowel is perforated and peritonitis is present, or if the patient is unstable, then additional measures post-operatively will be put in place. Post-op chemotherapy treatment is indicated when there's positive lymph node involvement noted during surgery. It's also indicated when there's been metastasis to other organs or tissue. So it's used in conjunction with surgery as a form of treatment. Chemotherapy is also used for treatment of colorectal cancer that is non-resectable. Radiation therapy is also used post-operatively in conjunction with chemotherapy or not. Okay, it can be done separately. As a palliative measure, its primary objective is to reduce the tumor size and to provide symptomatic relief. Overall goals of surgical management of colorectal cancer is to reinstill normal bowel elimination patterns and to improve the quality of life that's appropriate to the degree disease progression. In late stages of cancer, there's only so much that we can do to make our patients comfortable, but to the degree of the disease progression, we're going to do our best. We want to make sure our patients are as free of pain as possible and promote feelings of comfort and well-being. Again, health promotion point here: the American Cancer Society recommends that we start colorectal screening at the age of 50 with colonoscopies, or earlier with patients who are at high risk, such as those who have a familial background or those of African American descent. The colonoscopy is used again to detect polyps. It also can visualize abnormal bowel tissue representative of cancerous lesions. Some of the most distressing considerations for colonoscopies for patients is the misunderstanding of the prep. A A lot of people think the prep for the colonoscopy is really awful, and I think as healthcare providers we need to be positive spokespersons and dispel this myth. Um, 24 hours before the procedure, this is a scheduled procedure. The individual will be NPO except for clear liquids and a lavage solution that is to be taken. And what this does is this totally empties the colon. And you need to keep drinking this solution until the colon uh, what's expelled from the colon is clear and has no feces left in it. So then you're 24 hours, you wake up in the morning, you're NPO for 24 hours that night, you wake up in the morning, you go for the procedure, you're sedated, you don't feel anything, you wake up and it's all done. So it's really a pretty benign procedure, and the benefits certainly outweigh the risks or the unpleasantries that are associated with this test. Preoperatively, for any colorectal surgeries, you're going to want to provide your patient with education about their prognosis, about what the findings were, what the possible outcomes of the surgeries might be. You want to provide the individual with support in dealing with this diagnosis. You want to talk about the care post-operatively, what might be involved. If there's a chance that the individual might have an ostomy, a colostomy, or an ileostomy as a result of the surgery, you want to discuss that with the patient ahead of time so that they're better able to accept this if they wake up after surgery and they actually have an ostomy in place. So emotional support, you want to teach your patient how important it will be for them post-operatively to change positions, educating patients preoperatively about deep breathing is going to facilitate their ability to do it, and educate them that they're going to get up out of that bed on day one to promote peristalsis of the bowel and facilitate good bowel healing. If the procedure is done perianally, we're going to advise our patients ahead of time that sitz baths are going to lukewarm sitz baths will be ordered to promote healing and comfort. And again, a lot of education and a lot of emotional support. It's a pretty big surgery, and they're going to be pretty uncomfortable when they're first coming out of their procedure. Again, our management post-operatively is certainly going to depend upon the type of the wound that the patient has post-operatively. So our approach is going to be very individualized. There might be drains present, and they're going to remain in place until the drainage has become minimized. And typically, drains are removed when the drainage decreases to about 50 milliliters in a 24-hour period. That's a good indication that it's time to take the drain out. Let's see. I think I can move forward here. You want to assess any drainage, whether it's from a drain that's inserted or whether it's from the incision site or from the ostomy or from an NG tube. Any drainage needs to be assessed for the amount, the color, and the consistency. The wound needs to be examined regularly. Need to record any bleeding, any excessive drainage, any odor, etc. You want to monitor the suture line for infection. And you want to monitor the suture line and make sure that there's no evisceration, any separation of the sutures. In obese individuals, that's cause for concern. It's called evisceration. And individuals who get infection internally, peritonitis, typically that's going to result in an evisceration of a wound. So, just monitoring, real careful assessments of your patient will help detect any complications early on, and that's a sign of good nursing care. You're certainly going to want to help with pain control, provide any counseling patients who have questions or concerns about sexual performance post-operatively. These individuals may actually be concerned about any temporary impotence that may be a result of the surgery. They may be concerned about their body image if they have if the surgery has resulted in their need to have an ostomy. Throughout the entire hospitalization, a key role of the RN in managing this type of patient with colorectal cancer is psychological support. When it's time for that individual to transition to the home setting, the psychological support is maybe even more important because the individual is going to need to feel that they're not abandoned, that they still have the healthcare team behind them to assist them with questions and concerns and problems. I feel that this patient should not be discharged to home without a follow-up appointment already established. So they know by at a certain date and time they are going to be, seen by their healthcare provider. You want to make sure that they've been educated about any chemotherapy or radiation therapy that's been ordered, and make sure that they know how to properly care for their wound when they're discharged, how to properly care for their ostomy when they're discharged. So that discharge teaching with this type of surgery is really, really important. This is a diagram that shows you schematically where some of the common stomas are placed surgically. This next slide shows you a diagram of a loop ostomy. A loop ostomy is typically used for temporary periods only, and that loop that's protruding up that looks like a volcano or a thumb, that's actually part of the bowel that is pulled through an opening in the abdominal surface. And the tip of that little brown area is opened, and that's where feces, fecal material, is allowed to drain. Again, it's typically used as a temporary measure. We've talked a little bit about ostomies already, but again, preoperatively, the psychological preparation is very important, as well as involving the patient in the selection of the placement of the ostomy, if at all possible. This individual is going to need to be able to see the stoma, if at all possible, and they need to be able to manage the care of that ostomy themselves to promote independence. So finding a nice flat surface on the abdomen will facilitate good adherence of the ostomy appliance, so that's an important part, and hopefully you can involve the patient in that as well. We want to teach the patient how to inspect the stoma, what a healthy stoma looks like. We know a healthy stoma should be moist, it should be pink. Initially, post-operatively, there's going to be some slight bleeding, and there's going to be some moderate swelling, especially during the first 2 to 3 weeks after surgery. But that bleeding should become minimal pretty soon, and a bloody stoma is not, a couple of days post-operatively, it should not be any blood present. So pink, moist, healthy tissue, a dusky blue would indicate ischemia to the stoma itself. Brownish, blackish color is going to indicate necrosis, and the patient needs to be educated on that. Depending upon the location of the stoma, the individual may actually have formed or semi-formed stool coming out of the ostomy. If this is the case, as opposed to the case with ileostomies where the fecal material is very liquidy, if the ostomy is done in a part of the colon where the stool is formed or semi-formed, the individual may actually be able to achieve bowel control and may not have to wear a pouch. If a pouch is worn, however, approximately every 5 to 7 days, the pouch itself should be changed. And in between that, it's just emptied. I'd like to show you this next diagram and go through it with you and explain how individuals can use colonic irrigation to achieve bowel continence. This individual has a colonoscopy, and this individual's stool that comes out of the ostomy is semi-formed or formed. And through diet and through a routine, some individuals don't have to wear a pouch. And this individual is an example. And we're going to go through the process of irrigating the colon to expel the feces from the colon. It's very similar to an enema that you would perform, and it's very similar to an IV. It is a clean procedure, and the irrigation bag will be filled with between 500 and 1,000 milliliters of lukewarm water, not hot and not cold. So picture an irrigation bag the size of a bag of normal saline. And there's tubing, and the air is purged from that tubing just like you would purge the air from an IV bag. And the tip of the tubing is going to be inserted into the ostomy itself, into the stoma. And you see the gentleman is holding the tubing, and he's got like a cone-like structure. That cone is what's going to be the tip of that cone is what's going to be inserted into the stoma, about an inch or so into the stoma. And there's nothing to hold it in place or lock it in place, so the person actually has to hold it in place themselves while the fluid is being entered into the colon. So once the tip of that cone is in the stoma, let me go back a minute here. The patient also needs to put a special sleeve on so that when it's time to allow the contents to evacuate the colon, we can direct that fluid into a receptacle of some sort. And here you can see that the receptacle is the toilet. If the patient, if you needed to do this to a patient who is in bed, you could have the sleeve in a bedpan or in a basin of some sort. So the lukewarm water is in the irrigation bag, the air has been purged, the tip of the cone is in the stoma, the sleeve is in place, and the patient opens up the clamp and allows the fluid, the water, to flow into the colon for about 5 to 10 minutes. If cramping occurs, you just keep the cone in place. If you take the cone out, the liquid's going to come out, and it's not ready to come out yet. You want it to sit inside the colon for a few minutes to help it work best. It's the same concept as when we give a patient an enema. We tell them, okay, hold it as long as you can, because it helps to better evacuate the colon. So the same concept is in place here. But if cramping occurs, keep that cone in place, stop the irrigant from going in for a few seconds until the cramping subsides, and then proceed with the installation of the fluid until the desired amount is instilled, or until the individual feels a sense of distension in the colon, that, hey, that's enough. It feels full. It feels like I can't hold any more. Then the cone is removed, and the individual needs to remain in position for 35-40 minutes or so to allow the expulsion of all of the fluid that was instilled. So it's going to be a combination of the lukewarm water and the bowel that's being evacuated from the colon. And when that's all finished, the individual takes that sleeve off, pats dry his stoma area, cleans his equipment, lets it dry, and it's ready to be used again. Depending upon the patient's depending upon the patient's dietary habits, exercise pattern, bowel routine, they may need to do this once a day. Maybe they do it every other day. It's very individualized bowel routine. But so that is colonic irrigation of an ostomy to evacuate bowel. Next, I'm talking about ileostomies. We've already talked about that. Again, changing the pouch. The only thing I want to talk about here is is educating your patient about how much fluid they can expect to be expelled from that ileostomy. And according to Lewis, once the bowel has had an opportunity to adapt to the surgery, approximately 500 milliliters in a 24-hour period is an average output from an ileostomy in a 24-hour period. Again, even with an ostomy, the patient needs to have a diet that is rich in fiber, but low fiber foods initially, and then once that bowel heals, further introduction of higher fiber foods. This part of the discussion will be going over diverticulosis and diverticulitis. I think that there are three terms here that are very commonly misconstrued, and I'll do my best to clear them up for you. If you look on your slide in the lower left-hand corner, you see the term diverticula. Diverticula are sacs, little sacs or pouches of the mucosa of the colon. The presence of many diverticula is a condition called diverticulosis. Okay, it's the presence of many little pouches that are not inflamed. When those pouches become inflamed, it's called diverticulitis, and the inflammation can result actually in perforation into the peritoneum and cause peritonitis. Diverticular disease is very common, and the incidence increases with age. It's thought to be related to a deficiency in dietary fiber, and with the older adult, with a normal loss of muscle mass and loss of collagen that's present, or that commonly occurs with normal aging. People with diverticula can be asymptomatic. So another way of saying that is you can be asymptomatic and have diverticulosis. Diverticulosis is typically discovered, since there are no symptoms, during a routine colonoscopy. However, diverticulitis is more severe, and it's when the diverticula are inflamed and the individual experiences a lot of pain and discomfort. They have abdominal pain, there's bloating, there's flatulence, and there's a change in bowel habits. Typically, the pain is over an area of the affected colon. The individual often presents with a fever and an elevated white blood cell count, and there may even be a palpable abdominal mass. We know, however, with older adults, they're often afebrile when their younger counterparts present with fever, and they may not even have an elevated white blood cell count. So diagnosing diverticulitis may be difficult. This slide shows you a difference between diverticulosis, which is the presence of many uninflamed diverticula, and on the right-hand side, diverticulitis, when those diverticula become mucousy, pussy, or otherwise inflamed. Not the best diagram for diverticulitis, but I thought the one on diverticulosis looked good. X-rays help rule out other causes of abdominal pain, but the preferred diagnostic test for diverticulosis and diverticulitis is a CAT scan with oral contrast. To prevent diverticulitis, you want to have your patient eat a high fiber diet. especially in fruits and vegetables. You want them to have a low-fat diet and one that does not include large amounts of ingestions of red meat. We know that physical activity is helpful in preventing diverticulitis, and for obese individuals, weight reduction can also help prevent diverticulitis. The treatment for acute diverticulitis is to rest the colon and to decrease the inflammation. Um, Most cases of diverticulitis can be managed at home with oral antibiotics and clear liquids. However, if the case is severe enough, a hospitalization may be indicated, and the protocol for hospitalization then with diverticulitis would be NPO, probably bed rest, IV antibiotics and fluids. And again, most of the time it's manageable at home, but hospitalization might be indicated. They also may need to resect part of that colon. If that individual isn't able to manage that diverticulitis at home with diet and exercise and medication, then surgery may be an option. So again, hospitalization would be indicated at that point in time. Hernias. Hernias are simply protrusions of a part of our anatomy out of an area where it's normally kept to the outside the wall or the cavity. And so it's a protrusion of a viscus through an abdominal opening or a weakened area, like a weakened area of muscle in the wall of the cavity where it's normally contained. They can occur at any part of the body. The most common ones are in the abdominal cavity, and out of those, the most common is the inguinal hernia. A hernia is considered reducible if you can easily press it back into place. Okay, just by manual pressure, you can push it back into place. Now, that doesn't mean that when you remove your hand, it doesn't come back out again, but just that's called reducible. Or sometimes just laying down, gravity takes over, and the protrusion goes back into the abdominal cavity. An irreducible or incarcerated hernia is one that cannot be placed back into the cavity. And in this situation, it's possible that intestinal flow and blood supply might become obstructed. And if that's the case, the hernia needs to be repaired or removed. It's repaired. It's not a removal. They'll strengthen that muscular wall, put it back in the cavity. It's not typically a removal. The term for hernia repair is called a herniorrhaphy. And I'm going to go through herniorrhaphy of the inguinal type with you. So it's in the inguinal area, so there's going to be a surgical incision in the inguinal area, which is close to the bladder. So post-operatively, we're going to monitor for urinary output. In the male patient, you're going to monitor for scrotal edema, and it may be indicated that the individual wear scrotal support with like an ice pack to reduce the swelling and to also minimize some pain. We're not going to encourage coughing with an inguinal hernia. If the patient does need to cough, we would instead encourage splinting over the incisional site. We will encourage deep breathing to prevent any complications, any respiratory type of complications post-operatively. And we will encourage the patient to refrain from any heavy lifting for about 6 to 8 weeks post-operatively. We've discussed malabsorption syndrome when we talked about Crohn's disease. We talked about malnutrition in the narrated PowerPoint on malnutrition. Also, we talked about it with megaloblastic anemia. But right here, I just want to mention that malabsorption syndrome can be from many different causes, and it is simply an impairment of the absorption of the nutritional components of food. And we're going to talk about some of the common causes, the most common in being lactose intolerance, irritable bowel disease, and celiac disease. Cystic fibrosis is another common cause of malabsorption syndrome. So lactase deficiency is the deficiency or absence of lactase, which is the enzyme that's necessary to digest lactose, which is present in milk and milk products. Individuals who are unable to digest lactose, who ingest milk and milk products, typically experience bloating, flatulence, cramping abdominal pain, and diarrhea. Again, you can see how common those symptoms are with many of the lower GI problems that we've been talking about over the past couple of hours. But unique to lactose intolerance, those symptoms typically occur within 30 to 60 minutes after ingesting milk or milk products. So we're able to treat that by avoiding milk and milk products, using yogurt products instead, or the individual can also choose to ingest a lactase supplement so that it assists them in digesting the lactose that's present in milk. Celiac disease is a disease where tissue of the bowel is destroyed because of chronic inflammation. And the chronic inflammation is a direct result of the ingestion of gluten that is present in some of the grains, for example, wheat, rye, and barley, and oats as well. I know I don't have that there, but it should be. So the tissue of the bowel is destroyed because it's chronically inflamed. Symptoms of celiac disease include foul-smelling diarrhea and a lot of the presence of excessive fat in the stool as well. Flatulence and other symptoms of malnutrition. The treatment for celiac disease is a gluten-free diet. It halts the inflammation. So individuals need to be on a gluten-free diet for life. Table 43-35 on page 1050 in your Lewis text does go over some foods that are gluten-free. Basically, individuals need to stay away from any of the foods that are made with the grains, wheat, rye, barley, or oats. Corn flour products are okay. So things like cornmeal, corn tortillas, cornbread, what else? Polenta. Those would be some choices of grain products made from corn that would be tolerated by the individual. Important for nursing to know that gluten-free products tend to be more expensive than non-gluten-free products. So in order for individuals to be compliant with their diet, they may need referral to resources for financial resources to help them be compliant. This is a picture of an external hemorrhoid. A hemorrhoid is simply a dilated vein somewhere in the rectum. Dilated veins in the rectum that are above the rectal sphincter are called internal hemorrhoids, and hemorrhoids that are below the rectal sphincter are called external hemorrhoids. This hemorrhoid has actually prolapsed to the outside of the anus, and typically you'll have a patient This is a diagram taken from the text that just shows you, if you look towards the base, that's the rectum and the anus, and you can see the internal hemorrhoids are up above the sphincter and the external hemorrhoids are external. Hemorrhoids are thought to develop as a result of increased anal pressure and weakened connective tissue. The veins become dilated. Usually it's a result of straining, excessive straining when having a bowel movement. They can also develop as a result of the increased pressure that results from pregnancy, from chronic constipation, from heavy lifting, and from prolonged sitting or standing. Hemorrhoids are the most common reason for bleeding with defecation. Some of the symptoms of hemorrhoids include, again, bleeding with defecation, itching around the anus, a prolapse of the hemorrhoid to the external part of the anus, and pain. We want to encourage conservative management when possible, which would be making sure that patients have plenty of fluid in their diet and high fiber and stool softeners to promote soft stools and prevent constipation. We would encourage our patients who have hemorrhoids to avoid heavy lifting and sitting for long periods of time, and to use over-the-counter medications and drugs that are available to help manage the symptoms. They come in little, what do they have? Witch hazel. They're like a witch hazel to reduce the inflammation and to help manage the itching as well. If the hemorrhoids are severe enough, surgery might be indicated. Even though the surgery is minor and can even be done as an outpatient, the pain as a result of it is extreme. And you're going to want to help prepare your individual psychologically for that first dreaded bowel movement after they've had a hemorrhoidectomy. And what we can do is we can teach our patient to make sure that they have an adequate amount of bulk and fiber in their diet to prevent constipation or hard stool. So a softer stool is going to be less painful than a harder stool. And we can teach our patient to post-op hemorrhoidectomy. They're going to be utilizing a sitz bath, a warm sitz bath for comfort and to keep the area clean. And they maybe need to receive opioids for pain, especially until those first couple of bowel movements have been achieved. So here's a sample exam question. This is the last part of the presentation. I'm sure you're all tired. Which instructions will the nurse include in discharge teaching for a patient who has had a hemorrhoidectomy as an outpatient at an outpatient medical surgical center? A is incorrect. Okay? You don't want to maintain a low residue diet until the surgical area is healed. That would promote constipation and hard stool. Bulk up the stool through a high residue diet. We're not going to use ice packs on the perineal area. We're going to instead promote cleanliness and soothing and reduced pain through a warm sitz bath. We can, choice C is the correct choice here. We're going to educate the patient to take prescribed medications before a bowel movement is expected. And we certainly don't want to encourage our patient to delay having a bowel movement for several days until healing has occurred. Again, that would just promote constipation, very hard stool, and it would make the initial bowel movement more uncomfortable. So that is the end of this presentation, almost 50 minutes worth, and cross your fingers that when I stop the presentation and save it, that it saves correctly. Thank you. Please be sure to bring any questions that you might have to my attention so that I can address them for you.